So Epstein anomaly is not very common, but it's very testable. What I mean by that is almost all exams, you're going to see something about Epstein anomaly. However, if you know what it is and you see one in the lab, you can readily make your diagnosis. So there are some defects, classic defects in Epstein anomaly. And we talk about the septal leaflet of the tricuspid valve displaced towards the RV apex. Okay, and as a result of that, the RV appears to be very small. Okay, it's not the whole, it's not all of the tricuspid valve which is apically displaced. It's the septal leaflet which is displaced towards the apex, and it gives as a result of that, you get a very small RV, and you get RV myocardial abnormality because of that. Okay, so the associated lesions. So when you have Epstein anomaly, there are certain things that usually go along with it. Sometimes congenital heart disease tend to have, is not just one lesion, you will have multiple lesions. So with the Epstein anomaly, in about 50% of the cases, you'll have an ASD or a PFO. You may also have what we call Wolff-Parkinson-White syndrome, and this is an electrical problem where you have an accessory pathway, which is an abnormal conduction between the atrium and the ventricle. That's what Wolff-Parkinson-White syndrome is. You can also get a right bundle branch block in the ECG, EKG, or you may get a first degree AV block. So this is a 4-chamber view. Okay, this is the left side of the heart over here, and this is the right side. Okay, the important point though is if you look closely on the right, or in the right ventricle, you can see something right here. This is actually the tricuspid valve, way down here. That's why we say it's apically displaced. And it's mainly the septal leaflet which is displaced down towards the RV apex. Okay, all right. So how do you make the assessment? Well, you use your transthoracic echo, and you'll get a very large right atrium because the RV is compromised at the expense of the as a result of the RA being enlarged. So you get a very small RV and a large RA. Okay? So large RA because the septal leaflet of the tricuspid valve is apically displaced. And by doing so, you get a large right atrium and a compromised RV. The RV is small. And you will see, we talk about a displacement index. That's basically what you're saying is how much the septal leaflet of the tricuspid valve is displaced towards the RV apex. And the definition of this displacement index is the linear distance between the septal leaflet of insertion of the tricuspid valve and the mitral valve. That's a separation distance between the septal leaflet of the tricuspid valve and the mitral valve, and you're going to divide that by the body surface area. So that is why it is a distance divided by the body surface area. Okay, that's the displacement index. It is the distance between the septal leaflet of the tricuspid valve and the mitral valve, whatever that number is, and you're going to divide it by the body surface area. Okay. In these patients, you tend to get tricuspid regurgitation, and as mentioned before, up to 50% of patients may have a ASD or a PFO. All right, so the tricuspid valve is very low into the RV apex, mainly the septal leaflet. Okay, and you tend to get tricuspid regurgitation as well. All right, so again, it's not very common, but you know, it appears on all exams, very testable, and so you need to know it. All right, the next defect we're going to look at is tetralogy Fallot, and you have to know there are tetra mean 4. You have to know the 4 defects associated with tetralogy Fallot. You get pulmonary infundibular stenosis, that's obstruction at the right ventricular flow tract, okay? Overriding aorta, so you have a VSD with the aorta overriding the septum, ventricular septum, the ventricular septal defect, and right ventricular hypertrophy. So those are the 4 defects associated with tetralogy Fallot. Obstruction at the right ventricular flow tract, overriding aorta, a ventricular septal defect, and the right ventricular hypertrophy. All right, so the cartoon looks something like this. So this is your normal heart with the orientation of the different structures, whereas tetralogy Fallot, okay, so this is your right ventricular flow tract or pulmonary infundibular area, and you can see that there is a narrowing stenosis. So right ventricular flow tract obstruction or infundibular stenosis. Okay, you have the overriding aorta. Your aorta is right here. It overrides the ventricular septum, and you have a ventricular septal defect. And then the right ventricle, you can see compared to the normal, it's very thickened, hypertrophy. So it's right ventricular hypertrophy. Okay, so those are the 4 defects associated tetralogy Fallot. Okay, you have your right ventricular flow tract obstruction or the infundibular stenosis, overriding aorta, ventricular septal defect, or VH. What are some of the signs and symptoms associated with tetralogy Fallot? You can get a low oxygen saturation because you have the mixture of desaturated blood with saturated blood. So the saturation of the blood leaving out of the aorta is going to be reduced. Okay, so low oxygen saturation. And as a result of that, you can get cyanosis. Okay, so bluish discoloration because of the desaturated blood. Failure to thrive, okay, especially in babies, young kids. They do not grow at the normal rate. Dyspnea, shortness of breath. So you can get shortness of breath, which is a fairly common feature because of the right ventricular flow obstruction and the VSD. Digital clubbing because of the low oxygen saturation as well. And then polycythemia also result from the low oxygen saturation. Polycythemia is just an increase in your red blood cell count, that which is driven by the low oxygen saturation. All right, so again, on the echo, which gonna make your diagnosis, you're gonna have your ventricular septal defect, right ventricular hypertrophy, right ventricular flow tract obstruction. You're gonna see all of those things, and you can also get branch pulmonary. Well, you can get branch pulmonary stenosis. So when you do your Doppler study and you go into the pulmonary artery, you'll get evidence of obstruction, so pulmonary artery stenosis. You can also get pulmonary insufficiency, PR. All right, so this is sort of trying to show, this is a short axis at the level of the aorta, so you get some obstruction at the right ventricular flow tract. The right ventricular, you get a VSD, right ventricular hypertrophy. You see the RV wall is a bit thickened. Okay. So this is a parasternal long axis view. You can see that the aorta, which is right here, overrides the ventricular septum. And you can probably see the thickening of the ventricular wall. So you basically just do your just go through your routine, doing your echo, and you'll pick up the defects, okay? So other defects that's associated with tetralogy Fallot, you can get you can get branch pulmonary stenosis. So you can get left pulmonary artery stenosis. So that's why sometimes you have to go into the pulmonary trunk and into the branch pulmonary arteries and get your Doppler. You can also get a bicuspid pulmonary valve within about 60% of patients. You can also get a right-sided aortic arch. Also coronary artery abnormalities, ASD or PFO. So when you have an ASD or a PFO, there's a tendency to call that pentology of Fallot. And it's fairly common. So when we say pent, we mean 5. So pentology of Fallot is when you have an ASD or a PFO. Atrioventricular septal defect, anomalous pulmonary venous connection, partial or total, and can get scoliosis. So these are some of the associated features, associated conditions, or other defects associated with tetralogy Fallot. The other type of congenital heart defect we're going to look at is your transposition of the great arteries. Now, you have to know your anatomy in order to understand this fully, okay? So when we say transposition of the great artery, TGA, it's an abnormal spatial arrangement of the pulmonary artery and the aorta. So when the great arteries are the pulmonary artery and the aorta, okay? Those are the two great arteries. So when we say that they are transposed, that means their location is not in the normal position, all right? So there are basically two types of TGA. So try and look at it very simple. Don't because you can, if you have a confusing understanding, you'll never get it. So there are two types of TGA, a transposition of great arteries. There's the D transposition and the L transposition. With the D transposition, you have transposition of the great arteries. So a simple way to look at your detransposition is just that the arteries are reversed. Nothing else. The arteries are reversed. So instead of the PA coming out of the RV, the PA comes out of the LV. And the aorta, instead of coming out of the LV, it comes out of the RV. That's detransposition. With your L transposition, how I tend to look at it is, even though it's a transposition of the great arteries, the arteries, for simplicity, the arteries are in their correct position, the ventricles are transposed. So the pulmonary artery is on the right side, but the left ventricle is now on the right side, and the right ventricle is on the left side. So the aorta comes out of the right ventricle. That is a very simple way of understanding it. There's a little bit more to it, but sometimes people just don't get it. So this is a very simple way to understand the basics. So with your detransposition, just think of it as the arteries are transposed. So the ventricles and everything is in the same position, but the aorta comes out of the RV, and the pulmonary artery comes out of the LV. They're switched. Okay, and then with your L transposition, the ventricles are on the opposite side. That is a very simple way of putting it, but I'm going to show you the difference now. So with a detransposition of the great arteries, as we said, just think of it as the arteries are reversed. So the right heart pumps blood into the aorta, bypassing the lungs. So that's what you're saying. So the arteries are transposed. So the pulmonary artery is now coming out of the LV, and it's gonna it's gonna take your oxygenated blood, okay? So the oxygenated blood now is going to pump into the PA, and then on the right side, the RV is going to pump deoxygenated blood into the aorta. Right away, you realize that that's not really compatible with life, because if you're pumping deoxygenated blood into the aorta, that fetus or infant cannot really survive. All right? So again, the right heart, which is the RV, the RV is going to pump blood into the aorta, since the aorta comes out of the RV. And then the left ventricle is going to pump blood, that is oxygenated blood, into the pulmonary arteries, into the lungs. So this is self-defeating, because the purpose of the lungs is to oxygenate the blood, but it's getting oxygenated blood from the left side of the heart. Okay, so, and this is what we call, you can see it is in series, because the right ventricle is now pumping blood into the aorta, and then the aorta is going to take blood to the head and neck, trunk, and the limbs. Okay, so which is deoxygenated blood is going to pump. And then on the left side, the LV is pumping blood into the pulmonary trunk, and it's going to go to the lungs, which is oxygenated blood. It doesn't. So these two circulations not mixing at all. So this infant will not survive unless there is a defect. Unless there is a defect which allow mixing of your oxygenated blood to the right side, and then you'll get oxygenated blood going through the aorta to the body. All right? So that is your detransposition. Very simplistic explanation, okay? But if you keep that, you will remember it. As opposed to your L transposition, okay, where, as we mentioned before, is the ventricles which are now transposed, even though we say transposition of the great arteries. So the LV is on the right side and the RV is on the left side. The great arteries, for a very simplistic term, are in their usual position. Okay? So the pulmonary artery now and the aorta are transposed, even though we said, they're the orientation of the aorta and pulmonary artery is abnormal, right? But for simplistic term, the important thing here is that the ventricles are transposed. So the morphological left ventricle is now on the right side, and the right ventricles are on the left side. So they are transposed. All right. So because of what I just said, what you're going to get is deoxygenated blood, which is coming from your in the right atrium, is going to be pumped into the morphological left ventricle, and then into the pulmonary artery to the lungs, because I would say just the left ventricle is on the opposite side. So you're getting your deoxygenated blood from the superior vena cava. Inferior vena cava is going to flow into the right atrium, but the right atrium is going to pump blood into the left ventricle, and then the left ventricle is going to pump blood into the pulmonary arteries to the lungs. And then on the left side, oxygenated blood coming from the lungs is going to flow into the left atrium because it's in a normal position, but it's going to empty into the right ventricle, the morphological right ventricle, which is now on the left side. And that morphological right ventricle is going to pump blood into the aorta. So what is very important is when these patients come to the lab, you have to decide which side is the right, which side is the left. Because that's going to help you to make your diagnosis. Remember, we teach you that. If the AV valve, the lowest AV valve in the ventricle will determine which side is right and left. So what you're going to see is the lower AV valve is now on the left side. So right away, you should say that the RV and tricuspid valve is on the left side. And then on the right side, it's the LV. So you can quickly distinguish which is which using basic information, that we keep on stressing. But you have to remember that the RV and the LV is essentially on the opposite side. So deoxygenated blood is going to be pumped from the right atrium into the morphological left ventricle and into the pulmonary artery. Then oxygenated blood is going to pump from the left atrium into the morphological right ventricle and into the aorta. Okay, so this is your L transposition, which is different from your D transposition. So the RV is now on the left, but it's pumping blood into the aorta. The LV is on the right and it's pumping blood into the pulmonary artery. If you think back a little bit, remember that the RV is used to pumping blood into a low pressure system. The RV is used to pumping blood. It is constructed to pump low pressures. Now it's going to pump high pressures into the aorta. It's going to fail. The RV and the tricuspid valve is going to fail because of that. And this is one of the major problems with your L transposition. You'll get failure of the RV because it's not accustomed to pump blood, high pressure blood anywhere. Okay? So again, basic anatomy, the lowest AV valve is going to tell you the right ventricle from the left ventricle. So by just looking at it, you're going to say, well, this is the right ventricle. Okay? But what you're going to see is that the right ventricle is going to pump blood into the aorta, which is abnormal. Okay? Right away, you can make your diagnosis. But the RV is going to fail because it's not accustomed to pump blood into a high pressure area. So if you have that basic concept, I think you won't go wrong, and you can work out the other things that will follow. Okay, so for your D transposition, just think of it as in terms of just the arteries are transposed. The arteries are reversed, and you can see that the circulations are not going to mix. It's not compatible with life unless you have some type of shunter defects. Whereas your L transposition, think of it as in terms of just the ventricles are transposed, the arteries in their usual position. But because the RV is now on the left side and pumping blood into the aorta, it's not accustomed to pumping blood into high pressure areas, so it will fail. Patient will present with heart failure. Okay, so